Hello, everyone. This is Karen O'Hara. I'm the Director of Marketing and Communications with WorkCare. Thank you for joining us for the 11th week in our series on preventing and managing COVID-19 in the workplace. Many of you have joined us in these past weeks, and we really appreciate your participation. Those of you who are joining us for the first time, welcome. I'd encourage you to go back and listen to the previous recordings and the question and answers that we publish after each webinar. Alexis will post the YouTube channel and the website address where you can find those materials during the webinar. As you know, the session is being recorded, and we'll be distributing the recording within the next day or so on our YouTube channel. During the webinar, please submit your questions using the Q&A function on Zoom. At the conclusion of Dr. Harris's remarks, I'll be summarizing the questions, and he'll answer as many as he can in the time that we allow. We usually stay on for about 40 minutes. Let me introduce Dr. Harris. Anthony Harris, MD, MBA, MPH, is a board-certified occupational medicine physician. He is WorkCare's Chief Innovation Officer, Vice President of On-Site Clinical Operations, and an Associate Medical Director. Dr. Harris has been leading our COVID-19 response. Now I'll turn it over to him. Thank you.
Excellent. Thank you, Karen, and thank you again, everyone, for joining us for another exciting week of what to do about COVID, both in the workplace, and today we're going to touch on kind of a public workplace interface, if you would, in regards to how do we bring the business up and running if we are customer-facing entities, meaning we have patrons coming in and out of our doors, and we know we are working more and more with those type of employers and want to provide them as well some solutions that will help them reopen safely. So as we jump into the presentation for today, many of you who are rejoining us will be familiar with our format, and we'll keep it the same. Clinical update comes first, followed by kind of a pathology review and epidemiology review thereafter. We'll spend a little less time on the epidemiology for today and focus more on the preventative strategies and workforce strategies that we want to bring to bear to help our clients and to help the general public in this case as well to enjoy the services that they've come to grow and love over the years, right? So as we hop into the clinical update, there's not much new again on the horizon for presentation of COVID-19. We're all familiar with the litany of symptoms to the left there, but what we want to really focus in on is the classic picture of COVID-19, right? Sick individuals that are at home and quarantining is not the picture of COVID today, right? The picture of COVID today are the asymptomatic individuals. When we talk about how do we prevent the spread of COVID, it's really going to be a strategy of capturing the asymptomatic and allowing us to then get them in a quarantine scenario quickly so that they're not spreading the illness. And so we'll focus much of our time today talking about the strategy, not just for those who present ill, but mainly for those asymptomatic. So the microbiology update here is more of a recap and a clarification. We realized that over the last couple of weeks, there's probably been a little more confusion we've seen anecdotally amongst our clientele in regards to clarifying the different tests available on the marketplace and the efficacy thereof. And the first test that we all are hopefully familiar with are called molecular tests. These are the tests that look for nucleic acid, meaning RNA, of the COVID-19 SARS-CoV-2 virus. Okay, and so these are the swabs, either nasopharyngeal through the nose, the kind of painful appearing process, oropharyngeal through the mouth, or even saliva tests that have been FDA, EUA authorized, emergency use authorized. And so these are the tests that have historically been in the range of 30% false negative rate, and then down to 9% and then 3% if you take the test once, twice, and then 3 times. The improvements we've seen in this arena have been vast. To the extent where some of the tests on the market for molecular testing is efficacious as having a sensitivity of 99% and greater, and then also specificity of 100%. And so when we talk about the next sample of tests, they are serologic tests, and they're looking for antibodies specifically to COVID-19 or SARS-CoV-2. And so these are the venous blood draws that you've seen on the marketplace. These are also the pinpricks that you can acquire these days from ex-US and now starting in the US as well. And the antibodies are present in your system already, and the test is looking for a presence of those antibodies with this type of assay. When we talk about the third kind of category then for testing, and this is kind of the clarification piece that we want to make sure everybody's on the same page about, it's antigen testing. So the difference between antigen testing and antibody testing versus looking for the nucleic acid, antigen testing is looking for components of the virus, right? The classic example of an antigen test that you may be familiar with is a swab for strep throat. When you go to the doctor's office and they stick that swab in the back of your throat, dab it in a couple reagents at the bedside, and look for a positive result. That's exactly what this type of test is designed to do for COVID-19. And so it's several reagents after you do a swab that allows the tester to understand whether you're positive or negative for pieces of the virus. So how it differs is that it's not looking for nucleic acids of the virus, it's looking for different proteins. And so we've all seen this high-res graphic from CDC, and these small little pieces of material in the microscopic view of this virus represent these type of proteins that one of these type of tests can look for. And historically, these tests have been questionable in regards to their sensitivity and specificity. Recalling data we presented several weeks ago from WHO, these tests could range in sensitivity from as low as 35%, meaning 75% of the time they're going to miss a positive person, up to 86% sensitive. So we have, for the most part, have stayed away from these type of tests because of the high variability in the accuracy. If we look then on how we can tackle the vast number of tests that are coming out, certainly in this category, the improvements have been made to provide more accuracy. WorkCare has put together a comprehensive reporting, evaluation and reporting program so that we can examine tests for our clients and then recommend various tests. And this is for US and ex-US. And it's mainly focused in on a specific test, providing high yield information on the sensitivity and specificity of that test, the time for results of that test, as well as then ranking that particular test in a way that allows us to make recommendations of, yes, this is a test that we feel confident will provide you valuable information on making decisions on how to keep people safe at work or otherwise. And we also will recommend against certain tests because the data is just not there, or poor quality is the evaluation of that particular test. So it's critical to have this frame in mind when we talk about how we start to reopen, protect our workforce first and foremost, and then protect the well-being of our patrons secondarily, because testing is a key component of that, and as well, we want to make sure that the testing is moving forward in an efficacious way. So quickly, we'll touch on the epidemiology of SARS in the US right now, SARS-CoV-2. If we look at the number from last week, we were at 1.5 million total cases, 90,000 deaths. This week, 1.6 million cases and 98,000 deaths. So obviously, we're going to top the 100,000 mark probably in the next 2 weeks here is what estimates are projecting. When we talk about then reopening of the different states, we presented some data on that previously. Here's an updated map on states that have major restrictions still in place. Those are the darkly colored states in this case. Moderate states, meaning moderate restrictions, states that allow certain entities to reopen, barbers and beauty salons, and then those states that have minor restrictions in place are allowing for more open spaces, allowing for more patrons to be present, in some cases up to 50% capacity, and certainly in the case of restaurants, and that we're seeing outdoor spaces reopening, and then those states that have no restrictions in place. You can see there Utah, Texas, Wisconsin. And we want to quickly look at then, and we asked the question last week, are we seeing bumps in those states, particularly that have reopened? Certainly there are reports of states like Texas that have seen and reported their highest numbers since reopening, in this case 1,450 cases. States like Alabama have reported high numbers in terms of doubling of their cases. It yet to be seen, though, whether or not there's data that's going to substantiate causality, right? Reopen, and we touched on this briefly last week, where we see a correlation of increased numbers with reopening. However, that doesn't mean the reopening necessarily caused those numbers to spike. And so we'll report on that, and this is a plug for next week's webinar. We'll report on that and kind of dig deep into what we're finding in regards to causality. Does reopening cause cases to increase? For now, we'll look at then how we're doing overall in the US in regards to some key metrics that we've been watching week over week. In this case, the number of new cases on a daily rate. This is the flattening of the curve that we're looking for over a 7-day average is this particular graph. And we see that we're continuing to stay flat and decrease in the number of daily new confirmed cases overall in the US, as opposed to some of our brothers and sisters in South America, Brazil being hit really hard, India on the rise there, and they're still looking for their curves to flatten. And of course, we'll be paying attention to those figures as we move forward. If we look then at daily new confirmed deaths, we continue to see this curve decreasing in terms of its slope. So that's obviously another positive indication that we have done well with our social distancing and our recommendations for wearing face coverings, etc. But we still obviously have work to do to get us through coronavirus. And on a side note, if we talk about the epidemiology of viruses, if you look at some projections coming out of certain universities, we can see projections akin to what happened in the Spanish flu 1918, where social distancing was relaxed. And in fact, early in the Spanish flu, it presented itself early in the year. By summer, it had tailed off and there were a few cases. And then in the fall, Spanish flu, there was a deep recrudescence of Spanish flu, higher than the numbers seen in the spring. That is one of the projections for SARS-CoV-2, right? But there are also two other projections where the virus stays the same in terms of numbers, and a projection where the numbers continue to decline and be more seasonal, like a flu type illness. So again, these scenarios have been looked at and studied. We really don't know which scenario is going to play out, which is why we need to poignantly stay on top of these type of trends so we can be aptly prepared for such recrudescence if it should happen. So when we talk about then total confirmed cases per thousand tests per thousand people in the US. We've been watching this number to hopefully see improvements in our testing. In this case, we do have increased numbers per thousand individuals. If we look at it at an individual level of tests per 1,000, we're about we've been hovering around 1.3, 1.5 tests per thousand individuals. So hopefully with the new tests coming online, and again, there's well over 100 now, 90 to 100 EUA, FDA approved tests, we'll see an increase of these number of tests for our population. Daily new confirmed tests, again, point towards us increasing the number of testing well over 100,000 tests a day. So let's talk then about prevention, right? What are we going to do about reopening? Last week, we talked about reopening the business, not just for the employees, but we talked about stay tuning for today for customer assurance for those customer-facing businesses. We touched briefly on what our Shanghai Disneyland theme parks are doing with regard to reopening with a kind of red-green pass, if you would, and that's the same philosophy we've been doing for over at WorkCare for over the last 2.5 months now, and it works well in terms of keeping those ill out of the facility and keeping them safely at home quarantined. And when we look at then what's happening in the U.S., we also reported last week that there are similar measures being taken for continuing to try to reopen shops with social distancing, temperature checks, and the whole nine in terms of screening in place. So if we look then specifically at what states and cities are doing, let's take, for example, Chicago. I bring you greetings from Chicago every week. And when we talk about reopening here, there's some specific recommendations that have been made from the mayor's office in regards to how to reopen safely. In this case, for the food industry, restaurants, and they're requiring employees to be screened, right? And we see that not just from the local or state, but even at the federal level, still on the White House plan to reopen, having phase one, including some type of screening by employers for employees. And so prior to leaving home, individuals are encouraged to self-identify symptoms, right? Does that sound familiar? I hope it does. That's what we've been doing now for almost 2.5 months. And so when we talk about the establishment testing at the sites, being able to screen in some way, shape, or form, again, questionnaires for the employees, the self-screen is the recommendation for reopening restaurants in this case and food providers in Chicago. But now let's look at what the requirement is for restaurants for their customers. Right? And when we talk about what processes will be in place and recommended, they're recommending that the restaurant purveyor provide screening or a means for screening, whether it's a questionnaire, verbal agreement, or nonverbal, for their customers to assure their customer base that individuals that are patroning that location have gone through some type of screening. They're putting that burden, yes, on the employer. And then they're saying, yes, you should prohibit anyone with symptoms from entering your facility. So they're taking some significant leaps here to support restaurants or to position restaurants and other employers that are customer facing to provide these type of services. And certainly we want to be able to provide these tools from WorkCare and our partners in the clinical world to employers. And when we talk about then at the state level, in this case, Illinois, they even go a step further and say all employers should have wellness screening programs in place for their employees, right? And so it's a little bit more comprehensive in terms of what they're recommending for in-person and for shift testing in between. So how do we do that? We talked about it briefly we touched on it quite a bit last week in terms of providing tools for employers. We introduced the concept of COVID Clear Zone being a comprehensive approach for both employees, one, and for patrons, two. We went through with the employees pre-screening, site stratification, risk stratification, surveillance program, right? We won't touch on those too much today. We want to just keep your mind fresh on those things, but we'll focus in on, in a second, the patron approach. So when the daily screening and the risk stratification is in place, we're able to do risk stratification for the location and provide information on overall relative risk. We're able to provide a comprehensive program for employees, and then we can provide a strategy for not just testing, but for prevention overall, right? And certainly we talked about the testing. This is the strategy that we covered last week for employers. When we talk about then what's in place and what we're launching for patrons in the coming weeks here, it's really going to be touching on 3 types of approaches, right? On-site screening, pre-screening, and registration screening. So what do I mean by that? I mean, essentially it's laying out a methodology so we can go from empty restaurants, facilities to full of patrons, hopefully in the next couple weeks as states continue to reopen. And the first piece of that is to provide this on-site capability for the customers to self-declare any symptoms that they're having, right? And so this is the most simplistic form of that, having a kiosk type setting with an iPad or a mobile device so that customers can affirm that they in fact are not having any symptoms. Again, this is much aligned with what we've been doing for the last couple months, as well as what cities and states are requiring of employers to do for employees, right? And so the process is already in place. We're doing this with employers for some of their workforce that don't have digital access outside the workplace, and they're using a kiosk to enter their facilities, and it works well. And we know that then the second stage of this, or the second level to this, it goes a step beyond just the entrance to the place that people are patroning, to the point where they register and they have access to a screening tool, again, very much like what we're doing with employees, excuse me, and they're able to affirm prior to even showing up, before they leave the house, that they are indeed not experiencing any symptoms potentially of COVID-19. Right, and so when they leave the house, they know they're going to be able to enter the facility that they're destined to patron, and it's a win-win, right? The employer has a way to quickly assess and clear individuals to enter without any delay or long queues outside the facility, and the patrons themselves feel assured that anybody entering that facility has undergone the same process for screening. And that is the core of the COVID clear zone concept, right? We want to make sure that people are doing the right thing, but then also reassure others in their proximity that the same process is being put forth for everyone who's showing up. And then the third stage of this, and this is again a process that we are laying out and recommending for our partners that are in the entertainment industry, such as studios, in the theme park industry, and they have thousands of patrons that come through the doors a day, right? And what is the process? It looks very similar to what you're seeing in Shanghai in terms of having registration well ahead of time, in case where it takes you 2-3 months to even get a ticket to these facilities. Obviously, it's not a whim that individuals are going to make travel plans during COVID-19. And so there's time for pre-registration, weeks in advance, so that the facility can be assured that this individual who we're issuing a ticket to has participated in a screening process, plus or minus in certain cases, a testing regimen, which you see here, and as well as then once they have their ticket, to be able to on site then have a screening in-person process just on the day of, to then screen out those symptomatic individuals. So it kind of is a process that should not seem 100% new to you if you've been joining us week after week, because the approach is solid in regards to how we do COVID prevention, not just for symptomatic at the door, but for asymptomatic prior to, and then the testing piece of that playing a key role to this. So is this even feasible, right? The concept that we can roll out this type of program in regards to testing to the level that we know we need to get to, even testing at home, is still a work in progress, right? And we see LabCorp being the first test for home use collection, but we're even seeing leaps beyond that in terms of enabling innovations. This is a presentation by Andrei Bedinsky out of the University, out of Zuckerman Institute at Columbia University. And what they're looking at and looking to launch is a home test that uses color change with saliva that doesn't need any extraneous incubation. As simple as a warm water bath at home allows them to now test individuals to a cost-effective level that it can be done daily, even at a sensitivity of 95.6% and specificity of 99.4%. We won't get into the science behind it. We'll just mention it briefly. It's called LAMP. It's the LAMP assay uses a process not too dissimilar from PCR in that it amplifies the viral DNA or RNA, nucleic acid, to the point where it can be detected with this type of reagent process. And it's not too onerous, right? And in fact, when we look at then the testing regimen for such cost-effective approaches, Shaman earlier this year published research looking at predictive models of frequency of testing to help prevent COVID in the workplace. And again, these are frequency of tests for home use in general, and testing on a daily basis does in fact limit the most transmission of illness, as depicted with color change here, blue being less disease, yellow, bright yellow being more disease at the different levels of tests. So the daily test is at the very top. The twice a week test is Monday, Thursday, and the second line there, testing once a week, is the occurrence and model for the third line, and then no testing at all shows you the relative level of disease transmission in the workplace, specifically if you have or don't have a home testing process. So is it feasible? Is it doable? Are we weeks away? Are we months away from having such technology at play? Well, FDA, to answer that question, has approved back on May 15th the first home use, not just collection, but home use test, right? So it's collecting at home, it's testing at home, and this uses similar technology to understand, like we mentioned for the swab for strep throat, to help individuals at home safely identify whether or not they have COVID-19, and that can be an essential part of the future for us in regards to how we build these type of preventative measures for the workforce and for the general public. So more to come on that next week when we talk about, again, drilling into how we look at spikes of reopening of states and how do we combat that with new strategies. But we'll stop and hit the pause button right now, and we'll open it up to questions. Thank you.
Thank you, Dr. Harris. This is Karen again. I'm going to start off with a question that I have. Since I'm the moderator, I have the opportunity to be the first question. I'm thinking about the results that just were reported out of Texas, where there seems to be discrepancies in the number of tests being conducted in certain communities, certain populations, and underserved populations seeming to be getting fewer tests because of access issues. So I'm wondering about the technology that's necessary to do self-screening and reporting, which seems to be pretty dependent on the use of smartphones and access to laptops and an understanding of how to access information online. So if this strategy is going to work and reach all the necessary populations who would be potentially visiting a theme park, for example, how do you think that's going to work?
Sure. So providing access is going to be key, obviously, and for those underserved populations, partnering with local community health departments, county health departments, and state efforts are going to be essential to supporting those underserved communities that don't have and traditionally have lacked access to care, access to technology, etc. So we have to assume that these efforts are going to be focused in on those underserved areas primarily first and foremost, because we also know if we overlay incidents of disease, those are some of the hardest hit areas as well. And so when we look at Texas numbers, just to address that piece of your question, the increase in number of cases could be attributable to the increase in number of testing. That is a epidemiologic, well-known fact that if you test more, you're going to find more, right? What has yet to come to fruition is the substantial clinical studies to do the causality analysis of whether or not those numbers are reflective of behavioral changes, meaning relaxing of social distancing. And so we'll continue to look at that as things continue to unfold with the research.
Okay, thank you. How effective is the LAMP test? What's the rate of false positives and negatives?
Sure. So when we talk about the LAMP test, the one that we looked at for this particular instance, it's sensitive to 95.6%, meaning that it's only going to miss, right, 4.4% of the tests of those individuals tested that have positive disease. When we talk about specificity, then only 0.6% of people that have a positive test will have had a positive test because of a cross reaction with another virus. So those are very solid numbers when we talk about accuracy for this type of LAMP assay. And again, this is not the only LAMP assay coming to market. There are several others.
Do you have any cost estimates for these types of tests?
No, not at this point. Cost data has not yet been available from a commercial acquisition standpoint.
Okay, next question. How soon after exposure is a person then contagious to others?
Sure. So we know that with after exposure, within the first 48 hours, an individual can become contagious because of buildup of the virus in the system, the exponential growth of the virus. So that's usually the window where we're trying to capture also those individuals who are asymptomatic during that period, and they test positive, and we can get them quarantined safely.
Next question is, are there different guidelines for those companies that have been identified as essential workers as compared to workplaces that are non-essential?
Guidelines being a very broad topic, right? There's guidelines for PPE, guidelines for who can go to work and who can't, guidelines for return to work, etc. So in short, yes, there are different guidelines that CDC has put forth that clinical best practices denote as well for those essential workforce versus general population. The best way to examine how to understand those guidelines for individual different types of workers would be the phased approach to return to work put forth by the White House administration, as well as CDC, looking at a risk stratification approach to return to work.
Okay, question about self-reporting. How do you estimate the value of the pre-screening process when it doesn't include a test?
Sure. So we know that the screening is essential, right? We know that not just screening with IR thermography that's looking for fever, right? We're talking screening for symptoms. And we know that's going to be the front line for defense when we talk about understanding who is safe to be at work and who's not. So it is effective. Now, does it rely on the honor system? Yes. Does it rely on participation? Absolutely. But what we've seen so far, anecdotally, having done well over 500,000 daily screens with the workforces that we've been working with, is that participation is substantial because it's being mandated to get on the premises of employees, by employees. And we know that we've only had a very small fraction, far less than 1% of the individuals trying to game the system in terms of falsifying or false reporting. So we know that's going to be the front line. The testing is still essential when we talk about the inevitable reopening and sustainability of reopening and limiting spread of disease and understanding the burden of disease first and foremost in the US and tracking that. But again, we can't rely only on testing as a primary means. Primary example in Wuhan, where testing was widely available and they were knocking on doors to open to test individuals, they only estimated 41% of those with disease were tested, right? And so we know that is what we're up against when we're talking about the level of testing and the burden of disease that will be even beyond the testing in a ubiquitous testing environment.
Okay, we're getting a number of questions about WorkCare is going about screening, including daily, through the return to work process, and you kind of flew through that part. Just to answer one question, we don't typically endorse any specific products, but Dr. Harris could review our process again briefly of what we're offering, since a number of people are asking about it. So maybe you could just quickly review, go back to your slides on the starting with daily screening through what we're doing with return to work.
Okay, and if I understand the question correctly, just a recap of the process for daily screening, et cetera?
Yes, because we're, for example, we've been asked if we do return to work testing or do we only review results from being tested. And another questioner was asking about what we're offering in terms of daily screening and an app in general.
Got it. So yes, this is our comprehensive approach for we call it COVID Clear Zone now. We called it Return to Work as well as part of the Return to Work process. And it starts with this screening up front, right? If you don't have the screening up front, which is going to be the means to get symptomatic people out of the workplace and home safely quarantined, then the utility of doing testing and surveillance with testing decreases dramatically, right? So we want to have this in place. We do offer a digital platform, as we have for the last 2.5 months, to our employers so that they can quickly scale up. And our first engagement that time ago, we went from 0 to 20,000 workers in about 72 hours. So we have that in place and have been also doing boots on the ground, IR thermography to help with screening on site. And that has been going tremendously well over 300 locations that we have personnel on the ground helping out with our employers. The next piece of it then is to do a surveillance program. We call it COVID surveillance. It starts with baseline testing for either return to work scenario, if your workforce has been off for en masse, right? And then once you have a baseline test, putting people into a risk stratification through a COVID risk appraisal, which is behavioral based and as well as geographic based. And then their level of risk, high, medium, and low, predicts their scheduling for ongoing testing until we get to the other side of this COVID pandemic with the vaccine and herd immunity at 60 to 70%, right? So that is the COVID surveillance program. And we've been able to help roll it out with employers in different geographics already, helping them focus in on where their greatest need is from a business essential function standpoint, as well as highest burden of risk for COVID-19 to the workforce. And again, when we talk about not endorsing any particular product, that is absolutely true. We are technology or test agnostic in this regard. What we want to make sure we're doing in our role as clinicians is vetting the technology, vetting the clinical approach so that we can assure you the accuracy of the test based upon the data available from the manufacturer and from the clinical community. That's the role we've served, and it's done well for us to engage and start testing in a way that allows us to scale rather quickly because we're not locked into a single test. We want to make sure the tests are on par with their accuracy across the board. So hopefully that achieves the ask in regards to recapping those pieces of what we provide.
Yeah, thank you for going back over that. It's in a rapidly evolving series of services, so we'd like to keep people up to date. One last question we've been asked and answered before in Q&A, but since we have a minute left, I thought we could ask it again, and it's about concerns about aerosolization of the virus in shared restroom facilities and whether that should be a concern, and if it is, what steps can one take to prevent that contagion in the public restroom or at a workplace?
Sure. In general, aerosolization of the virus is a concern. Think of it as a cloud of, an orc cloud, if you would, of particles around an individual, right? It's kind of their zone of breathing where their particles we're talking about that are suspended in air are smaller than 5 microns. And those are the ones that are carrying enough virus to be infectious in nature. Those typically can exist in a radius of about 3 feet. And so when we say social distancing of 6 feet, that gives us a buffer, right? And that's the studied safe zone in terms of distancing. The heavier particles from like a cough or a sneeze, 20 microns or greater, fall to the ground within that distance. And so they're not as much of a concern, but those that are suspended in air, we know can be suspended for up to 3 hours. Studies have shown. So we want to make sure that we are doing the proper precautions for helping prevent infectious spread to others if we are a carrier asymptomatically by wearing our face covers. In those public bathrooms, if you're not, basically if you're in public and you're not wearing a face covering, there is potential for you as a carrier to transmit. That is why we across the board recommend face coverings, particularly in the workplace. Aerosolization otherwise in the laboratory can occur, and some studies looked at the method of drying your hands and have recommended that using paper towels or a manual process for drying the hands would be preferred over a air blower hand dryer, because the virus size is smaller, substantially smaller than those of a bacterium. So those hand dryers that blow to dry the hands do not distribute bacteria to the same degree that they potentially distribute and aerosolize viral particles. And so we recommended some time ago in this series trying to, if you can, shy away from those blow dryers, those hand dryers that use air. So those are the methods. I have yet to see any fecal oral studies looking at aerosolization from viral particles that we know are shed in the fecal route, but hopefully over time here we'll see more of those studies come to fruition so we can plan accordingly. As of right now, there's nothing to that we've seen that substantiate a increased risk from aerosolization in the laboratory versus other spaces that are likewise confined in terms of geographic ability to social distance.
Okay, we're out of time, but we just got a couple questions about spirometry. It says some on-site clinicians have suspended doing spirometry and some have not. Shouldn't this be suspended across all sites? Is there any new information regarding spirometry or audiometric testing?
No new information. Recommendations were across the board and pretty clear that spirometry should be suspended. And unless there's some mitigating circumstance that requires it from a clinical treatment standpoint. There's nothing new in that regard. In terms of audiometry, those type of processes that do not require increased risk for aerosolization or transmission, there hasn't been any direct guidance in terms of shutting those type of things down, although we know clinics have stopped screening processes across the board just to limit transmission from a social distancing standpoint.
Okay, well, I want to thank everyone for their questions, and you'll be amazed, Dr. Harris, we got through all of them this week.
Hey,
so we'll
good.
be summarizing those and printing them, and I won't have to chase you down for more answers. So, we're always happy to take your questions, so if you think of anything afterward, feel free to send them to us. I just want to mention that we have a special webinar coming up in addition to next week's weekly briefing with Dr. Harris. This is a follow-up to a previous one we did on mental health aspects featuring our Associate Medical Director, Brittany Bussey, MD. The topic is navigating mental health cross-currents as employees return to work. And she's going to be talking about aspects of independent choice over screening activities and participating in requirements for return to work, as opposed to, the need to protect the community and anxiety, dealing with the idea of returning to work, and safety being a fundamental need to feel comfortable. It's going to be a really good webinar. It's June 9th at 10 a.m. Pacific, and we'll be sending out a constant contact invitation to you all later today. So again, I want to thank Dr. Harris, as always, for filling us in on the latest with COVID-19, and we hope you all stay safe. Thanks again.
Thank you, everyone, and stay safe.